Most people in this space argue that food improves health, but when it comes to scale, a food as medicine benefit is only successful when it can be placed in the right reimbursement lane, defined as a service, linked to a cohort, tracked through encounters, interpreted through PMPM, and converted into a clear procurement and renewal decision. Hi, I'm Christina. Apologies for the technical difficulties today. But I want to talk about how only over a handful of over 100 food as medicine organizations actually meet that standard. So today I'm going to walk you through how to evaluate food as medicine as a payer grade healthcare benefit. I'm speaking today about how interventions are defined, delivered, and translated into financial impact within existing reimbursement structures. The framework is designed for payer, provider, and financial leadership responsible for approving, structuring, sustaining benefits, and it reflects how decisions are made in real environments where interventions must be measurable, auditable, and aligned to payment pathways in order to move forward. So we'll take a quick poll here. And one of the silver linings of having to switch platforms off the cuff here is that you have access to the chat. And LinkedIn Live, I don't think gives you access to the chat. It's like only a comment function. But if you can, just think about it for a moment. And I want to know which of these is hardest to demonstrate in your opinion about food as medicine. Okay, so we have C, maybe B, proving financial impact. Absolutely. So really it's all of the above. But I think it depends on who you ask. So if you're looking at clinician level, operational level, it's what breaks down is on intake, right? Ensuring the right people get the right kind of intervention, food that makes actual sense for them to eat, and also making sure that they actually get the meals, that they are equipped to, that the intervention is delivered appropriately. From an actuary standpoint, it's at attribution, but all of the above are correct because those things need to be in alignment for the system to actually work. And so most programs don't have that structure that's required for financial decision making. Evaluation depends on a defined cohort, a clearly specified unit of service, and encounter level logic that connects delivery to reporting. So without these elements, outcomes cannot be translated into PMPM impact. And without PMPM, the intervention cannot be assessed, approved, or sustained within a payer environment. Now, food as medicine is actually having a moment right now because it's crossed that structural threshold from an optional benefit into a regulated, auditable healthcare service. And Medicaid ILOS now requires defined service categories, clinical appropriateness, and encounter-coded reporting within a capped cost structure. In Medicare Advantage, supplemental benefits like food produce must be submitted as counter data records, categorized, validated, and monitored by CMS. So this means that payment is no longer based on intent or outcomes. It's dependent on data completeness, documentation, and auditability. And at the same time, encounter data is no longer a back-end reporting function. It's the payment system itself. So every service must be translated into a standardized format and mapped into the correct codes and submitted in a way that can pass state and CMS validation. And if that chain breaks at any point, coding, submission, or documentation, the result isn't just inefficiency, it is claim rejection, recoupment, or contract risk. And this is why audit exposure now defines financial risk. Medicaid requires ongoing cost reporting and retrospective evaluation with audit rights that can extend up to 10 years. Medicare Advantage is tightening enforcement through reject edits and active monitoring of supplemental benefit data. Food as medicine programs are now audit-bearing financial instruments where liability sits with the payer regardless of who delivers the service. And at the same time, policy volatility is increasing scrutiny rather than flexibility. And the rollback of federal HRSN guidance has shifted decision-making to a state level, creating more variability and higher thresholds. New programs are expected to meet stricter standards for measurement, documentation, and cost effectiveness. So because of this, the competitive advantage has fundamentally shifted. By 2026 and beyond, the organizations that succeed won't be the ones with the most compelling programs, but the ones that can demonstrate clear lane alignment, produce encounter grade data, and generate evidence that holds up across cost, utilization, and equity measures. So expectations versus reality here is that food as medicine is a program, that it's a social good, it's benefits, that it's one thing. But really, we're moving into how to actually evaluate programs in the current environment. So we need to reframe this thinking of food as medicine as a program and into a system, because systems have predictable outputs depending on the right inputs. So I'll walk you through that framework. Before we evaluate any program, we have to understand the lane that it's operating in, because each lane defines what counts as value. And this is where a lot of the confusion comes in. Most organizations will say, we do multiple things. We reduce utilization, we deliver a defined service, we improve outcomes. And all of those things can be true. But for evaluation and for payment, we don't evaluate across all of those things at once. We evaluate within the constraints of a specific lane, because each lane has different rules, different time horizons, and different ways that value is recognized. So a lot of organizations early on will sort of throw spaghetti at the walls and report everything and sort of leave it to the buyer to figure out how to pay them. But when you do that, you mix signals, you lose your clarity, and you lose the ability to measure impact and defend results and get paid. So, for example, in Medicare Advantage SSBCI, this is not primarily a cost savings play. The value is in member retention and performance on STARS measures. So rather than asking, did this reduce hospitalizations, we're asking, did this improve adherence? Did this stabilize members? Did this protect or improve STAR ratings? And those effects often show up over a longer time horizon and not immediately in claims. In contrast, like in 1115 or in HRSN programs, the intervention is structured as a defined service. This is closer to a fee schedule model. So evaluation focuses on clear unit definition, delivery consistency, and eligibility compliance. So the question becomes, was the service delivered as defined? Can it be reported, billed, validated? Because in this lane, the service is not, if the service isn't structurally defined, then it's not fundable. Then we go to ILOS. The cost suppression here becomes primary. Here, the expectation is reduced ED use, fewer inpatient admissions, lower total cost of care, but only under specific conditions like high-risk populations, targeting in a short, well-defined time window. So the evaluation in this lane is a little bit stricter. You need more of a defined cohort, a defined window, and claims-linked utilization change. Because if those aren't present, then the savings doesn't hold. And then post-discharge is different again. This is an episode-based lane. So the goal here is to stabilize the patient immediately after discharge. So we're looking at 30-day readmissions, complications, and short-term utilization. So evaluation here is highly time-bound. So if you measure too late, you lose the signal. But if you measure too early, then you can lose the effect. So when someone says our program reduces utilization, but it's also a defined service, then the response, that's not a problem. But we still have to choose how to evaluate it. Because if you try to evaluate cost savings inside of a service definition lane, then the financial signal may not show up. But if you try to evaluate service delivery inside of a cost suppression lane, then it won't meet the threshold for savings. A program can certainly operate across multiple lanes, but it cannot be evaluated across multiple lanes at the same time. So you have to anchor the evaluation to the primary financial mechanism. And really the quickest question to ask yourself is, if this program disappeared tomorrow, what would I feel first? What would be impacted first within the system? And so whatever is impacted first is usually the primary lane that you want to use for evaluation. And so the reason why we don't structure it multiple ways at once is because each pathway requires that different structure with the different cohorts, different time windows, different attribution methods and data systems. So if you try to do all of that simultaneously, you'll end up with a model that's very difficult to measure. So instead, we choose the lane first and then evaluate the program based on what that lane allows us to prove and how that lane recognizes value. Because across all of these lanes, the intervention may look exactly the same, but the evaluation is going to be completely different. Each lane defines what outcome matters, what time frame matters, how value shows up financially. So the goal is not really to prove everything. It's just the right thing in the right lane in the way that can be recognized and paid. So the programs that scale are the ones who can do that clearly, because programs, when they do fail, they're often fail because they're evaluated outside of the logic that they live in. So evaluation requires a defined cohort, a specific service, a clear time horizon, and a valid comparison. And that's the model that we're going to work with today. So we'll start off with cohort. So many programs might say, well, we serve 500 people, we reduced ED visits, but they don't know, they can't say who exactly, or you reduced ED visits out of how many. They might say participants improved, but then you want to know compared to what population. So without a stable cohort, PMPM is meaningless. Utilization rates are distorted. Your savings can't be calculated, and then you can't really compare that model. So finance really can't use that. What we want to see for a valid cohort is a clearly defined population with explicit inclusion and exclusion criteria that's supported by continuous enrollment over the evaluation period. And that establishes a stable denominator for all outcome and financial calculations. So I'm going to take you through a real world example just with public information. So you see that one organization starts with a tightly defined cohort that's food insecure members with specific conditions like CHF or diabetes, with explicit thresholds, clear inclusion and exclusion criteria, and a fixed time window, for example, 8 weeks of meals or 12 weeks of coaching. Because that population is defined, then everything downstream becomes measurable, and they can track how many were screened, how many were eligible, how many enrolled, and how many completed. And they can calculate engagement, compare pre and post outcomes, and translate that into PMPM savings or utilization impact. The model becomes bounded, testable, and ultimately underwritable. So then you look at organization B that operates with more of a broadening and shifting population without clear eligibility thresholds or a stable denominator. So at the same time, the service definition itself is inconsistent, and that further destabilizes the cohort. So the takeaway here is that a defined cohort is what creates your financial object. Without a cohort, you have no denominator, no PMPM, no counterfactual, but with a cohort, the model then becomes fundable and repeatable and therefore auditable. And so a cohort definition is your entry point into financial governance, and it's the first moment when that intervention becomes really legible to capital. So now we'll look at a valid service definition, and I'm going to walk through another example. So this is 3 organization types, 6 individual organizations, but just over 3 types, and how much it impacts program evaluation, when we look across these three comparisons, the first thing to focus on is the service definition itself. Even in a high clarity case, you see that the service is narrowly and explicitly defined. So for medically tailored meals, organizations that have a high clarity service definition will define the service as clinically prescribed intervention tied to a specific diagnosis and delivered over a fixed duration. In food prescription models, a high clarity service definition defines by eligibility, duration, scope within a formal program structure. And then you have food benefits, and that's monthly allowance tied to a condition and controlled through care management. So in contrast, you look at the three low clarity examples. The service is described as a combination of multiple activities. The intervention is certainly present, but the service itself is not defined as a single and bounded offering. Then we want to look next at the unit definition. This is where divergence becomes operational. So high clarity models, each service translates into a single consistent unit. And medically tailored meals are defined as meals delivered at a set frequency over a defined period, and that's an episode. Food prescription programs defined a time-bound benefit or a structured intervention period. Food benefits reduce even further into a simple financial unit, such as per member per month allowance. And these units are stable and repeatable. In lower clarity models, the unit is either fragmented or absent, and the service is a service a meal, a visit, a referral, an educational interaction, because multiple components are bundled together, so no single unit can be consistently priced or tracked. And the absence of a unit is not a minor issue itself, but it means that there's no standardized way to represent the service in a financial system. The same pattern appears in attribution strength. Again, we see high clarity models define specific population and time horizon, and this creates a stable denominator and allows for outcomes to be measured against a counterfactual. This makes it possible to assess whether the intervention changed utilizations or costs. In the lower clarity models, the attribution is more diluted because the service spans multiple activities and populations, and it becomes very difficult to isolate the effect of any single component. So those outcomes may still exist, but they're harder to attribute directly to the intervention in a way that meets payer standards. So finally, when we look at real world outcomes, we look at strength, contracts, scale, stability. The pattern is consistent across three comparisons. High clarity services are more likely to be contracted, repeated, scaled, because they fit within existing payment structures. They can be approved, audited, renewed. Lower clarity services, even when impactful, tend to operate through grants, partnerships, or pilot programs. And they may reach large populations and demonstrate meaningful outcomes, but they remain adjacent to the financial system rather than integrated with it. So taken together, these comparisons show that the difference is not the underlying intervention. Across all of these cases, organizations are addressing either nutrition, chronic disease, food access, but the difference is structural. So when that service is clearly defined, reduced to a unit, and translated into financial terms, then it becomes a part of the healthcare economy. But when it's not, it remains, of course, valuable in the work itself, but it doesn't convert into a repeatable and reimbursable product. So a valid service definition requires a clearly specified unit of service, such as a meal, box, allowance, a defined episode, along with an explicit dose and duration parameters. This structure enables consistent measurement, reporting, and translation into financial impact. So then we'll look at operational fidelity that requires consistent measurement of completion rates, tracking of missed deliveries, and adherence to defined timing standards. So delivery must be verified at the service level to support valid outcome interpretation and financial analysis. So next we'll look at time. Time is a tool for program evaluation, and I want to compare two organizations. Excuse me. So time determines whether impact can be measured, recognized, and trusted. And it's actually one of the strongest defenses against the wrong pocket problem. So when we compare post-discharge meals to open-ended food access, the difference is not the intervention, it's timing. So in one case, the service is tightly structured around a specific event, and that's a hospital discharge. Members receive a defined number of meals within a short immediate window measured in days to weeks. That timing directly aligns with the period of highest readmission risk and acute utilization, which means that any impact can be observed within the same claims window that the payer is already tracking. And as a result, the intervention can be evaluated, tied to a cost event, and justified financially. In contrast, on the right side delivers ongoing food as access as a continuous support model, and that intervention may be equally valuable or even more comprehensive, but it operates over an indefinite time horizon with no defined start or end. So benefits accumulate gradually over months or years without clear evaluation tied to a specific utilization event. Because of this, there's no clear way to measure impact of a cost period, making it difficult to link the intervention to reductions in healthcare utilization. The key distinction is that both of these models provide food support, but only one is anchored to a cost-relevant time window. So if the evaluation window does not align when the effects actually occur, then the impact may not appear in the data, and this is where finance disconnects. When the time window is misaligned, then savings don't show up, PMPM remains flat, and ROI appears non-existent even when the intervention is working. So time also defines your attribution validity. So if the window is too short, then there's not enough signal to detect change. But if it's too long, then the results are diluted by churn, external factors, unrelated events, and the result is noise instead of insight. In practice, time is the mechanism that connects the intervention to the measurable financial outcomes. So here we come back to the tension between alignment and attribution, because time data architecture is really underrated. As any clinician will tell you, as I said earlier, the part where the most models break down is in alignment to begin with. When members can't actually eat the food, they can't chew it, or it doesn't make sense to them culturally. It got sent to the wrong place. So your data architecture should be structured to consistently tell the story about how the program is aligned end to end with how they plan to get paid. So the data architecture requires a complete flow from eligibility through referral, delivery, and encounter submission, with member level linkage across each step. And encounters must meet acceptance standards to support validation, reporting, and financial interpretation. Non-duplication controls require that verification that services don't overlap with existing benefits, along with consistent checks for concurrent support. And these controls ensure that utilization is appropriate and that resulting financial outcomes are valid. Then your outcome measurement, it should be anchored in PMPM as the primary financial metric, with secondary tracking of emergency department use, inpatient utilization, pharmacy spend, and all outcomes must be translated into dollar impact to support evaluation and decision making. So at the program level, you don't have to actually call it PMPM, but at some point, every program gets translated into a per member financial impact to support a funding decision. So the requirement is the same, defensible financial impact per population. Then we'll look at a study design. A minimum study design requires a defined comparator and appropriate covariate adjustment to account for population differences. Pre and post analysis alone doesn't meet the standard for evaluation. What matters at this stage is not just that outcomes improved, it's whether those outcomes can be attributed to the intervention with confidence. And that requires three things. First, a comparator. We need to know what would have happened to a similar population without the intervention, whether that's a match control group, a historical baseline, or a risk-adjusted benchmark. And second is your covariate adjustment. Patient populations aren't uniform, so differences in acuity, comorbidities, and social risk must be accounted for, or the results will be biased. And third is that we can't rely on pre and post comparisons alone. Improvement over time doesn't equal impact, especially in populations where regression to the mean or seasonal effects or concurrent interventions are at play. So without a comparator or proper adjustment, then we're measuring change, but not necessarily causality. And without causality, then there's no defensible financial translation. And so the goal is not to make every food is medicine program run a randomized trial. The goal is to choose a study design that's credible enough for the decision being made. So I have a helpful table for the right design type and use cases. So feel free to take a screenshot of that so you have it later. Market dynamics reflect that food as medicine performance depends on alignment with reimbursement lanes, with outcomes shaped by how services fit within defined payment pathways. Vendors that demonstrate audit-grade data, documentation, and reporting capabilities are much more likely to sustain contracts. Current conditions show that progression from policy development to capital allocation, followed by increasing emphasis on governance as the determining factor in scale and continuation. So it's an important signal because there is a lot of policy momentum right now. Policy creates the opportunity, but policy alone doesn't determine scalability or fundability in the long term. What we're seeing across markets is a sequence of first policy opens up a reimbursement lane and then capital begins to flow in the form of pilots, grants, and early contracts. But what determines whether that funding continues is the governance itself, specifically whether the service can be delivered, documented, and reported in a way that fits the payment pathway. Programs that align tightly with those requirements tend to convert into sustained contracts, and programs that don't may still, of course, show strong outcomes, but they remain in pilot cycles. So the question isn't really whether the policy exists, it's whether the programs are structured enough to operate inside that policy as reimbursable, auditable service. Decisions here are structured to either approve, refine, or pause based on verified operational performance and PMPM financial impact. So at the end of all of this, the goal isn't just to produce an analysis, it's to support a decision. If you approve, then approving means that the program is operationally working. You're seeing utilization movement. The financials are trending in the right direction. Refine would mean that something is working, but not everything. For example, they have strong operations, but weak financial signal. Then they might need a longer time horizon, or they have strong results, but in one subgroup only. Then you want to see them tighten up targeting. Pause would mean that the delivery is inconsistent, the outcomes aren't working, the financials are negative. So in that case, you don't scale, but pause and fix the model. So at the end, what you want to see ideally is a final PMPM or PBPM, a cumulative net impact, confidence ranges and not just point estimates, group variation, and any operational bottlenecks. So let's walk very quickly. I'm going to take 5 minutes, probably less, to evaluate, to run through this full framework. Somebody asked me recently, how do we evaluate a food as medicine program for pregnant populations? pregnancy is actually one of the strongest evaluation cases structurally, because you have a clearly defined population, a defined eligibility window, high cost downstream events. You have a time window that's very clear. It's prenatal, delivery, postpartum, and then outcomes that are clinically and financially meaningful: preterm birth, NICU utilization, maternal complications. So each of these outcomes has a clear cost profile. So this becomes an episode-based evaluation and not a vague long-term model. So even if you start with operational data, delivery rates, and engagement, then you can structure the program so that it's ready for claims-based evaluation, cost modeling, and payer decision making. And so what you end up with is that episode-based stabilization, high-risk episode management. So even though it's for a specific population, it's exactly the same structural logic as, say, a post-discharge meal, CHF stabilization, post-NIF transition support. So sustained scale requires that services withstand audit conditions through consistent documentation, validated encounters, and defensible records. And funding decisions are determined by structure and performance of payment systems. So that is where I'm going to leave it today. If you don't remember anything else, it's that survivability and sustained scale requires that services withstand audit conditions. That's the point of today. Please feel free to get in touch with me. That is my email below. Of course, you can find me on LinkedIn. Thank you so much for switching platforms today, and I'm always happy to jump on a call or answer any questions that you might have after this. Thank you.